that was used impulsively by the FDA to slap a black box warning on testosterone. And none of those effects, none of those outcomes have been shown in trials or full prospective cohorts. None of that's happened. And so it's one of the things where you can't ask the FDA to take something back, but I believe that they really didn't care because testosterone's been demonized. They don't want physicians to prescribe testosterone. And so, it's just one of those things, but it's something that we have to live with. But the black box warning came from those two studies, and it was never amended.
Welcome to Old Guy Talks to Me, a podcast dedicated to helping guys create kick-ass lives for themselves and those that they love. Ladies, if you want to know what your guy is thinking, this podcast is for women too. Each week, a special guest helps you create that life you've imagined. We talk anti-aging medicine, personal growth, relationships and hot sex. Yeah, you hear me, getting laid more frequently, other guy vices, and topics that many don't want to talk about but need to. Just because you're getting older doesn't mean you have to be old. Don't want to miss anything? Be sure to subscribe, share, rate, and review this podcast. And be sure to go to www.thestandard.academy/magazine and grab a free copy of our new digital magazine, The Standard Academy, where we talk about erogenous zones, growing hair back, and other things that will help you create that kick-ass life. Now get ready to listen up and share with friends.
And see, this is increasing around the world. It's not just in the United States.
Oh, yeah. This is worldwide.
And see that what really bothered me that this group, Levine's group, was hammered by the Harvard group because that they could labeled in their analysis Western and other, and so they threw in a racial or ethnicity component that other races weren't being assessed. But the problem with that is there was no data there. And so in the 2022 study that was just published, they pulled the extra 7 years of data that was more geographically diverse because it was there. It was actually recorded. And so the previous stuff was based on the cancer registry data that was already there. And some countries just do not have that type of data. They don't have that infrastructure.
Yeah. So you have a young male. And it was interesting what you said about the male infertility issues, because a number of gynecologists that I've had on my podcast have spoken that increasingly they're finding that it's the man who's the issue in the conceptualization process with low sperm counts. And follow the money. There's actually private equity groups forming money, raising money to create sperm banks, because they're seeing this as being a factor. Yeah, there's those private equity groups that actually are now engaged in sperm banks, and so it's kind of an interesting thing. So let's say that you're a man in your 20s or 30s. There's two factors I see. One is the sperm count is low, but let's say your testosterone is low. How do you? And I know you're not a physician, but we can put that disclaimer in there. But how are they treated, and how do they maintain their whatever little fertility that they have in terms of that? What are the options out there for someone?
So from the top, could you restate exactly what you said from the first?
Well, I'm saying is that let's say somebody has low testosterone, they're in the 20s and 30s, and they want to increase their testosterone, but they still want to maintain their fertility, because my understanding is that the testosterone will lower your sperm count.
Yes.
And so that's always a big concern. Like, okay, well, I want to get on testosterone, but I still want to be able to have children with my wife. How's that issue addressed in raising testosterone levels in men?
Well, how I teach practitioners to address this issue is, number one, they have to have a sperm analysis done before treatment. So we have to know, because the subset of analysis of that study I told you about, they looked at men with normal sperm count as well, a subset in that study. But interestingly enough, in that whole set of men with normal sperm counts, all the factors of deterioration in sperm quality, the motility, morphology, all that stuff was declining at the same rate it was in the other men that had lower sperm counts. And so just by that data and other data from several other studies, we have to know if the male is viable in the first place. Because if he goes on testosterone, is not tested out, and then tries to conceive afterward, it's going to be really frustrating. So the best bet for any young man is to have the sperm checked. Have a sperm analysis done, see where you're at, then bank that sperm. Bank it. And so if that's, and that was one of the things I was going to say when you mentioned banking, that anyone that's going on testosterone therapy and they want to increase their levels, they need to have that done. Not only it's a litigation thing for a practice, but it's also just a common sense thing for the individual to do. And there's other methods that can be done if their sperm is fine. Then they don't necessarily have to go on testosterone treatment. I would recommend it, but there's other lines of treatment that have to be offered first or given as options. And these include HCG, human chorionic gonadotropin, and also clomiphene. And so the thing about those is clomiphene is a selective estrogen receptor modulator. It increases the risk of thrombosis. A lot of bodybuilders that take clomiphene and tamoxifen, they end up developing thrombosis because of that, because it has a higher thrombotic risk. With HCG, it's not identical to the luteinizing hormone that's produced in the body. Does it increase the testosterone levels? Sure, it does. But with both of these, it's an artificial inflation, because you just don't improve the testosterone levels and then think that the whole axis is going to shift to a higher set point. No, it's going to go back to the set point it was, and the testosterone levels will be the same unless there's lifestyle factors involved. And so, in my opinion, if someone is, if they have testosterone deficiency and they're very low, they need to go on testosterone, because the other stuff will give some degree of increases. Even aromatase inhibitors have been used to artificially increase testosterone levels. I do not recommend that in any stretch of the imagination.
Right. So let's do a quick why not, because they're real popular. They're real popular in some of these T-mills.
They are, and you know, we receive so many patients from testosterone mills where they put them on just a standard injection once per week or once every 2 weeks, along with a aromatase inhibitor schedule. All these men, and they have to phlebotomize on a regular basis too. So a ton of these men almost had iron deficiency anemia, and they're just feeling like crap, and they have erectile dysfunction. Ask them the first things about it, the classical stuff, and then when I dig into it, they've been prescribed aromatase inhibitor. And so the easiest way to get erectile dysfunction is titrate up 0.5 milligram of Arimidex per day until the person's dick gets limp or penis gets limp. I mean, that's just how it is.
Yeah, no, and I gather there's also some issues with heart disease and with aromatase inhibitors also.
Oh, definitely. The major pathology in bodybuilders that abuse high dose androgens is their use of aromatase inhibitors, because it blocks the protective effects of estrogen binding to the myocardium. And so without those effects, there's collagen infiltration that goes through the myocardium. And at some point, I believe this is linked to sudden cardiac death, because from the Purkinje fibers, from the apex through the Purkinje fibers, the depolarization of the heart cannot occur when there's so much collagen at some point. And so a lot of the case reports that I've looked at of sudden cardiac death show diffuse collagen infiltration throughout the heart. And some of these hearts weigh almost 1,000 grams. I mean, we're talking about over 3 times the size of normal. But this is
Okay,
during
wow.
conditions of abuse. But men on testosterone therapy, the same thing can also occur, because
Right.
if you knock out the protective effects of estradiol, number one, estradiol is required for libido. And so if you
Right.
knock that out, that's another risk factor for erectile dysfunction.
Sure,
So-
sure. And we've talked about this, and I want to touch on it again, just briefly here, that there is a ratio, and I guess I'm going to say it, I just want to make sure that I'm saying it correctly, that there's a ratio that's individually set genetically in each man between their testosterone levels and their estrogen levels. And that's, if you mess with that ratio, that's when you start getting into problems. Is that correct?
Well, I don't like to call it a ratio. The aromatase gene auto-regulates itself, and it
Okay.
controls the amount of aromatase. And so it auto-regulates that for each individual. And so what you see from the dose response trials, where they used 25 milligrams of testosterone and anthate in graded doses, they kept on going up all the way to 600 milligrams per week over a 6-month period. When you look at those dose response trials in both younger and older men, when you compare the older men, there was one study by the Bassine group, you can see that estradiol does not keep on rising exponentially. In
Okay.
younger men, it jumps up and then it levels off. And the reason why it levels off is because the aromatase enzyme is saturated. No more testosterone can cause an increased estradiol once the aromatase enzyme is saturated.
Okay.
It just
All right.
can't happen. So the autoregulation of the aromatase gene is what does that for each individual. Now, the testosterone to estradiol ratio is something that has been completely misinterpreted and abused in literature. And it's used, a lot of clinics want to keep someone within a testosterone to estradiol range. And they base this off of a study by Pavlovich in 2001 of individuals with male factor infertility that have some type of genetic disorder, either unknown or they had Klinefelter syndrome. And so in Klinefelter syndrome, that is one genetic disorder that is a primary testicular type of hypogonadism. And where was I going with that? I was getting ready to bring that back to one point, and it just left my mind.
Estrogen production. In
those individuals with Klinefelter syndrome, they have overexpression of aromatase, and so their LH levels, their FSH levels, and their estradiol levels are high, but their testosterone levels are hypogonadal. And so in those men, you would want to use something to correct that internal dysfunction of the hormones, the imbalance. You would want to do that. And so the testosterone to estradiol ratio established in that study is used by virtually every clinic, but they don't read the study. You can't extrapolate that from a morbid population to otherwise healthy men.
Sure.
And so that's the reason why I don't like to call it ratio, because but it's fine like that.
Okay. So actually there's a set point above which you won't get any more estrogen production regardless of the level of testosterone that you have.
Yes, and that accounts for every enzyme in the body.
Sure. Okay.
Mm-hmm.
Yeah, I want to talk about the two big, and I was like sitting next to a physician and we were talking and somebody asked like, well, does testosterone increase your blood pressure? And she went, yes. And I said, no. And I think that, there's the two big studies that everybody quotes about heart disease and testosterone that have been refuted by just about everyone on the planet, including, I believe, the authors have also come out against the conclusions. And there was also a consensus paper from the Mayo Clinic that refutes those studies, but still physicians quote those like it's the word of God.
I think you're talking about Balergian from the Mayo Clinic. And
Yeah,
I believe he was the author on that.
Yeah, I don't remember the authors, but I remember there were two papers that were consensus papers from the Mayo Clinic, but the two I can't remember now the two studies that people that talk about heart disease and testosterone, they were highly faulty. Could you talk a little bit about
Finkel and
yes.
vegan? Those two studies were secondary data analysis. With the vegan study, it was
so Scott, what does that mean, secondary data analysis?
Okay.
Do you need accountability? Are you looking to change the course of your life but have failed to keep on track? Too often we take in information and fail to act. Do you need an accountability program to stay the course? Then go to www.thestandard.academy and find out about my accountability program that goes with my course that helps you find out what you want, why you want it, and how to get it. The accountability program keeps you on track to get results.
To give like a bird's eye view of research, the only way that we can establish cause and effect if something causes something else to occur is to use a randomized controlled trial that is placebo controlled and blinded, and there's random allocation. Now, the studies that they used are at the lowest level of evidence, right above a case report, which is anecdotal, really. And so we can't establish cause and effect. We can only look at associations and correlations because there's nothing that's controlled there. And the problem with secondary data analysis is called harking, hypothesizing after the results are known. And basically what you can do with secondary data is you can omit data, twist the data to get the outcomes that you want. And who's going to know unless they go back through and do the forensic on how you cleaned and coded that data set. Now, a secondary data analysis does not control for anything. It just takes insurance claims data, a diagnosis, what was claimed, and an outcome that was linked in that patient's file.
Mm-hmm.
And all these studies do not factor in the use of tamoxifen or aromatase inhibitors along with testosterone replacement, which is really big. Every one of these studies negate to address that confounding factor. And that is the major confounding factor that skews the studies that show that there is some risk with testosterone therapy, but it's not the testosterone therapy. The risk is mediated. It's interaction effect through the aromatase inhibitors or the SERMs. So basically from the vegan study, it was veterans secondary data, and the sample actually included 40 or 50 females, and it was a male study. So how in the hell can you not tell the sex of someone, or you just include it in because it's going to inflate the point estimates? How does that get published in JAMA? How does that happen? And then after it's published, when there's so much concern that happens, why doesn't JAMA retract the article? That article still sits on the website along with their video that they made about the initial results of that study, not after it was critiqued. All that stuff is still there. Physicians still look at it. And so it's a big issue. But these two flawed studies of secondary data analysis, not what the FDA uses to approve drugs in trials and experiments, but secondary data analysis and observational study, that was used impulsively by the FDA to slap a black box warning on testosterone. And none of those effects, none of those outcomes have been shown in trials or full prospective cohorts. None of that's happened. And so it's one of the things where you can't ask the FDA to take something back, but I believe that they really didn't care because testosterone has been demonized. They don't want physicians to prescribe testosterone. And so, it's just one of those things, but it's something that we have to live with. But the black box warning came from those two studies, and it was never amended.
Okay. I'm going to switch gears here a little bit. You are involved in a new enterprise called OptimizeU Now. And that's the word optimize with the letter U and then now.com. Why don't you tell us a little bit about what that is and what you do and what your function, what the organization is, and what you do in the organization.
Great. Thanks for asking about that. OptimizeU it's a clinic that's focused on, it has some preventive medicine stuff, but it's also newer technologies, newer treatment paradigms. There's also like a cold therapy and stuff like that for athletes, things like that. But we also do a lot of hormones. And the main part of the practice is hormones. And it's about, we believe that there's optimal levels for everything, that there's an optimal amount of physical activity, there's an optimal amount of testosterone where you have the most benefits and the least side effects. I mean, and that applies to everything. And so OptimizeU, I was said after I left the previous practice, I had it in my mind I wasn't going to go back to another practice. I wasn't going to work in another practice at all. But when I was approached here by a fellow named Josh Hudson that started the clinic here only about 4 or 5 miles from my house, I was very impressed with how he took time with his patients, didn't rush them through in 15 minutes, really, and they only schedule blocks out a specific time for each patient so they can get that 45 minutes, whatever time it's needed, even on follow-ups. And so their attention to care and their concern for patients, they're always available. That's really what set them apart for me. I would probably say this is one of the most forward-thinking practices that is out there. And Josh, I believe it's Josh Hudson and Jerry Smith that are the main owners. Excellent guys, excellent people. All the practitioners that I've met in different states, everyone is on the same page. They want to get people healthy. They want to attenuate type 2 diabetes. They want to help people get in the best health that they can get in.
Yeah, and they do men and women, because I know we were talking a lot
Yes.
about men here, but they're basically both men and women in those areas. And so, yeah, and you got, there's a number of locations that you can find on the website, and that number is expanding. You already have a good number of locations basically around the United States, and it's expanding. So it's a great deal.
Well, they're also very selective in the clinicians that they bring on. And addition to that is we are starting OptimizeU Health Sciences, and it's a medical education, continuing education credit company. And so with this, there's going to be a lot of interesting, when you do continuing education credits, a lot of the stuff is just boring and you just have to get through it to be able to report. We're going to have a lot of interesting stuff that is directly applicable to hormone practice, even other areas inside of medicine and things like that too. So that's something that I'm going to be lecturing about. I'm going to be traveling. I'm going to be going around the country doing a lot of stuff.
Okay, great, wonderful, wonderful. Well, Scott, thank you for coming on board here. It's been very interesting. We covered some new ground and we covered some old ground, and I think that was good. I got to have some clarification, especially about the aromatase inhibitors in terms of the functionality. But really appreciate it. Look forward to seeing how you progress with OptimizeU Now. And there was also Scott's email is going to be in the show notes if you want to get connected with him. But check out the website, and because there's lots of good information there. And I think it can make a difference in the quality of your life, and that means the quality of the life of the people that you love too. So, so if you have not already gone to the standard.academy/magazine, get your free digital magazine. With one of the articles is "One Secret Place to Touch a Woman." And it's not her clitoris, because that's not a secret place. So just to tell you that. Be sure to get your free digital copy, and so you can create the life that you want. There's lots of other good articles in there too, but that's obviously the clickbait article. So remember, until next time, it's all about creating a kick-ass life for yourself and those that you love. Until next time.
Thank you, Orest.
Thank you.
Thank you for joining Dr. Orest and his incredible guest. Like what you heard and learned? Then be sure to do 3 things. 1, subscribe so you don't miss the next episode. 2, share this with someone who may need to hear it. 3, leave a review and rate this podcast. Opt in at www.thestandard.academy/magazine and get our free digital magazine with savings, articles, and deeper dives into cool controversy. Be the guy who takes action. Without action, you're not going to get the results you want. Thank you again, and make it a great day.